Hi, I'm Kristen Wall. I perform my placement at QML Pathology at the Mater Hospital in Bundaberg. This particular laboratory is known as a stat lab, which means the majority of tests are packaged and transported to Brisbane. However, tests such as INRs and coagulation studies, urgent biochemistry, full blood counts, urines, beta HCGs, troponins, D-dimers, group and holds, and blood cross matching are performed in this laboratory. QML Pathology is a service that provides primary healthcare and liaises with medical practitioners, patients, and allied health professionals by performing hematology, biochemical, microbiology, cytology, immunohematology, and molecular testing within a laboratory setting. Currently, QML Pathology has 24 laboratories and over 365 collection centres throughout Queensland and New South Wales. These facilities are run by over 32 specialists and over 32 staff. QML is one of Australia's major pathology services, which provides diagnostic testing and specialist diagnostic advice. These services begin at the collection of the specimen from the patient, to transportation of the specimen to a laboratory, reporting and interpretation of results to the referring doctor. These tests are provided range from cholesterol to molecular testing to genetic anomalies. These tests allow for the treating doctor to prevent illness, diagnose disease, guide treatment pathways, monitor disease progression, and eventually confirm recovery. Approximately 70 to 80% of healthcare decisions are reliant on diagnostic tests performed at QML Pathology. Pathology offers drug testing for employers to monitor employees. They are also a leading laboratory uh, for drug and alcohol programs. QML also offers wellness testing and screening for life insurance assessments, immigration services, pre-employment and occupational assessments. QML performs clinical trials for biotechnology, pharmaceutical and medical companies who want to develop new medicines and devices. Clinical trials are performed internationally, and many research organisations send their samples to QML for testing from all over the Asia Pacific. QML is contracted to perform veterinary pathology through their Vetnostics division. Vetnostics provides hematology, cytology, histology, and biochemistry testing. There are some specialised tests that can be performed by QML pathology. These include plasminogen activator, glycogen stimulation test, extended RAST, allergen testing, glucose tolerance test with insulin, sweat test, growth hormone exercise test, synthactin stimulation test, ischemic limb lactase test, water deprivation test, clonidine growth hormone stimulation test, and pituitary test. There are many laboratories located. Oh, there are many laboratories located all over Queensland. These include Brisbane Central Laboratory, Everton Park, Spring Hill, Auchenflower, Bundaberg, Cairns, Emerald, Gladstone, Rockhampton, Ballina, Pindara, Benoa, Tugun, Ipswich, Toowoomba, Mackay, North Lakes, Buderim, Redcliffe, Noosa, Gympie, and Townsville. QML was founded in the 1920s by Dr. Noel Gutteridge and Dr. James Duhigg, whom established pathology practices in Brisbane. They established an exceptional reputation as pioneers in private pathology, which enabled them to expand and build more pathologies. This was the first service of its kind. Their sons Bruce Gutteridge and Robert James Duhigg inherited QML pathology in 1974. Bruce Gutteridge and Robert Duhigg then amalgamated under the name Queensland Medical Laboratory, also known as QML. QML continued to grow throughout Queensland and the northern New South Wales. QML eventually partnered with other pathologists who allow QML to be more innovative and having the ability to provide the most sophisticated technology available at the time. In 1999, QML was renamed QML Pathology and continues to operate as one of the major pathology services in Queensland. The mission statement of QML is, our mission is to deliver better insights into the health of more Australians. Their values include each treating doctor's needs come first, an unquestioned commitment to quality, improving each patient's care in our ultimate goal, relentless improvement in everything we do, perpetual focus on improving performance driven by exceptional people working together, to build trust through integrity, teamwork and accountability. Building trust is key to delivering on our mission. We strive to be honest, dependable and forthright. We take ownership and accountability in everything we do. Their quality statement is, we have an unquestioned commitment to quality in everything we do. We see this as our key core value of partnering with referring doctors to better each patient's care. QML is accredited by NATA, the National Association of Testing Authorities. QML has extensive internal quality programs. They have continuous participation in quality assurance programs such as Royal College of Pathologists. QML have accreditation and compliance with QML Management, Australian Standards AS/ISO 15189 for medical laboratories. QML is the only Australian network with the Therapeutic Goods Administration for accreditation in microbiology laboratory facilities. Pathologists within QML must retain fellowship of the college and participate in ongoing professional development. One of the major objectives of QML pathology is continual development. This is achieved by developing new laboratory tests, evaluating current diagnostic tests, outlining validations for laboratory diagnostics, and improving interpretation of laboratory test results. QML pathology sets high standards for performance of laboratory diagnostics and aim to seek innovative ways to improve their services. Tools and products in order to assist treating doctors attaining pathology results, to assist in diagnostic and management of health conditions. Improvements in QML include, they were the first pathology organisation in Australia to do blood cross matching. They were the first private practice in Australia to have a radioisotope licence. In 1967, they offered superannuation 20 years ahead of their time. And in 1974, they were the first practice in the world to become computerised. QML has an effective community continual development program to ensure that staff has the most recent training. In order to achieve this, QML is part of the largest provider of continual development events for general practitioners in Australia. QML are the largest trainer of pathology registrars in Australia, and QML staff are required to obtain their qualifications through an externally credentialed organisation. My research topic associated with this placement is based on severe congenital neutropenia from a case of a 2-year-old girl, which I reviewed her film in the pathology I was doing placement at. I found her blood cells were normochromic and normocytic. However, only 2 neutrophils are seen on the entire blood film. The clinical notes indicated a known history of neutropenia and lethargy. Severe congenital neutropenia, or SCN, is a heterogeneous disease that has a high incidence of developing into leukemia. Leukemia can occur when there is an increased mutation rate in the hematopoietic stem or progenitor cells, or by promoting clonal hematopoiesis. SCOCOA ETAL added SCN is a pre-leukemic bone marrow failure syndrome with a 20% risk of evolving into leukemia or myelodysplastic syndrome. SCN is characterized by low numbers of neutrophils seen in peripheral blood, with an absolute neutrophil count of less than 500 cells per microliter, and significant susceptibility of life-threatening bacterial infections. These infections have led to sepsis in 21% of cases within this study performed by Triet ETAL in 2004. Haikang C 2013 performed a study on a 17-month-old Korean girl with SCN. She was admitted to hospital with cervical lymphadenitis caused by methicillin-resistant Staphylococcus aureus. She also had a history of Pseudomonas aeruginosa sepsis and peritonitis at 8 months of age. The mother and her 37-month-old sister also had SCN with the Elaine gene mutation. Unfortunately, the little girl did not respond to granulocyte colony stimulating factor, also known as GCSF, and underwent prolonged antibiotic treatment and excision of infection. In the event of bacterial infection, neutrophils are the first line of defense. Neutrophils follow several chemotactic gradients and are generally abundant in the blood and pass through the endothelium, then make their way to the infected tissue where they release vesicles laden with proteolytic enzymes and antimicrobial enzymes. When the neutrophils encounter a bacterium, they capture, ingest, and kill them by producing oxygen species. Having a lack of neutrophils results in immunodeficiency. The mortality rate of SCN is 70% in the first year of life if there has been no treatment such as GCSF and or hematopoietic stem cell transplantation. SCN was discovered by Rolf Kostman in 1956 in Swedish Kindred when he performed a study of 14 children affected by the disease. The name SCN is also interchangeable with Kostman syndrome. Other infections that can be a consequence of SCN include pneumonia, gingivitis, or cellulitis. Patients with SCN generally have pus collection at the site of inflammation as a result of reduced neutrophil granulocytes. Patients may also experience gastrointestinal inflammation and in some cases are prone to fractures as a consequence of osteopenia. Zia found that there is a CSF3R mutation found in patients with severe congenital neutropenia, which is not detected in healthy patients without the syndrome. When making a differential diagnosis of SCN, the CSF3R must be considered as a biallelic mutation when determining genetic subtypes. Consequently, the P.ARG308CYS mutation in CSF3R leads to altered GCSFR glycosylation and surface expression and rescinded downstream signaling. According to Triet ETAL, all patients within their study with CSN all had morphological evidence of full myeloid cell maturation in bone marrow. Unfortunately, all these patients within the study did not respond to treatment with recombinant human granulocyte colony stimulating factor, or RHG-CSF. These results of this study are concerning because RHG-CSF is the main treatment for CSN. RHG-CSF is known to improve quality of life, increase absolute neutrophil count, and reduce infection frequency in most patients. However, these results are after 10 years of treatment. Triet ETAL also found that the variability in morphology and genetic variances affect the functional importance and redundancy of GSF receptor-mediated signaling in human granulopoiesis. GCSF is known to induce proliferation differentiation, and the survival of myeloid progenitors. GCSF, it signals the receptor GCSFR through the cell surface, which is a member of the type 1 cytokine receptor superfamily, encoded by the CSF3R. Meta HETA 2015 has added hematopoiesis is a highly proliferative process involving several growth factors, cytokines, resulting in proliferation, survival, and differentiation of hematopoietic stem, progenitor, and precursor cells to a terminally discerned and functional cell type. Granulocytes are the most abundant type of white blood cells within the human circulatory system. Granulocytes play a fundamental role in innate and adaptive immunity. Granulopoiesis is mediated by several growth factors, including GCSF and GM-CSF. Other gene mutations that can cause CSN include ELANE, GFI1, HAX1, G6PC3, VPS45, and WAS. The genetic mutations of these genes resulting in SCN is still unknown. In cases of inherited SCN with mutations of ELANE or HAX1, which show typical myeloid maturation and arrest promyelocyte to myelocyte differentiation step, and generally have positive response to RHG-CSF treatment. SCOCOA ETAL found that patients with CSF3R and RUNX1 mutations have elevated proliferation of CD34 plus cells. SCOCOA ETAL conducted a study which included 31 patients with congenital neutropenia, and 64% had the RUNX1 mutation and 80.5% had the CSF3R mutation. 70 to 80% of patients develop acute myeloid leukemia and myelodysplastic syndrome, and at 2 to 28 years of life, and require chemotherapy for treatment. However, the prognosis is very poor for these patients. There has been no correlation found. There has been no correlation found with gender and age for congenital neutropenia and development of leukemia or myelodysplastic syndrome. ELANE gene mutations are known to be correlated with more severe neutropenia and several complications associated with SCN. ELANE gene mutations can also be identified in patients with cyclic neutropenia. Bone marrow findings include myeloid hyperplasia with maturation arrest at the promyelocyte stage. Patients may also present with mouth ulcers, stomatitis, with fevers and otitis media. NUSTID ETAL added different mutations of ELANE, and SCN patients have one common characteristic. The misfolded ELANE protein activates the unfolded protein response. Consequently, the accrual of misfolded proteins in the endoplasmic reticulum causes cellular stress, which triggers three membrane-bound stress sensors: incital requiring transmembrane kinase or endoribonuclease 1. Eukaryotic translation initiation factor 2 alpha kinase 3 and activating transcription factor 6, resulting in upregulation of protein folding. The stimulation of activating transcription factor 6 is then initiated in CD33 plus myeloid progenitor cells. Okay. In most cases, types genetic SCN, whether they are autosomal dominant or recessive, they can be more sporadic than inherited. In genetic heterogeneous with mutations such as ELANE or HAX1, neutrophil elastase is synthesized in early myeloid development during the myeloblast to promyelocyte transition. Consequently, neutrophil elastase accelerates apoptosis in differentiating myeloid cells. HAX1 is predominantly associated with mitochondria, mitochondrial membrane potential, and apoptosis. Consequently, increased apoptosis due to mitochondrial membrane potential causes flawed granulopoiesis during neutrophil differentiation from HAX1 iPS cells. This is a similar process seen in SCN patients with HAX1 gene deficiency. Marishima et al. In 2014 discovered when there is a genetic correlation of HAX1 in induced pluripotent stem cells from a patient with SCN, there is an improvement in granulocyte cells when treated with cytokines. So my conclusion is, unfortunately, the prognosis for this little girl is quite bleak. Continual monitoring is required for the risk of severe infections and the development of leukemia or myelodysplastic syndromes. Regular screening of full blood counts is required to assist with management of the disease. A medical scientist and a general practitioner or specialist will need to work as a cohesive team to ensure the best possible outcome for this little girl. Thank you for listening.